ಪ್ರಾರ್ಥನೆ. ಎಲ್ಲರೂ ಸಂತೋಷವಾಗಿರಲಿ, ಎಲ್ಲರೂ ಆರೋಗ್ಯವಾಗಿರಲಿ, ಎಲ್ಲರೂ ನೋವಿನಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲರೂ ದುಃಖದಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲ ಆಸೆ ಆಮಿಷಗಳನ್ನು ಮೀರಿ ಗುಣಪಡಿಸುವವರು ನಾವಾಗಿರಲಿ. Now the flag celebration shall be our light and strength, and its course shall be our course. We pledge our allegiance to it. Our responsibilities as the accredited members of this national organization, we swear we will dedicate everything in our power to see it fly high in the comity of nations. Jai Hind, long live IIM.
Thank you, sir. Now I would like to request Dr. Raghavendra B.S, President IIM Mangaluru, to welcome the gathering.
Good evening, everyone. Esteemed members of this association and our postgraduate students. So this is our regular monthly meeting, which the second Friday. Last month we had two meetings, on laboratory medicine on the second Friday and the fourth Friday CME on gastroenterology. That was on reflux disease, gastroesophageal reflux, and medical and surgical management. So we thought this month meeting will have a neurology CME. So when we approached Dr. B.S. Raghavendra, he happily agreed to speak on TIA. Dr. Raghavendra is well known to this audience. However, as a customary introduction I will do, he is a neurologist by profession and he is head of the Department of Neurology at Father Muller's Medical College, Mangaluru. He has been awarded with the multiple gold medals during his undergraduate and postgraduate training. He was a student of KMC Mangaluru, undergraduate as well as post-graduation. He has authored innumerable articles in various national and international journals. He has into his credit being the author of rare science in neurology, like heart cross, reverse heart cross, bun sign, panda cup sign, wrist and jaw clonus. He has received a lot of awards, and his famous article Single Doses Does Matter, for which he was invited as a speaker in Frankfurt, Germany. He was invited as a speaker in Zurich conference for his case series of neurological manifestation in COVID patients. And he is the author of one of the largest series of primary intraventricular hemorrhage and Moya disease. He also received iconic healthcare leader award, neurologist in 2022 by Golden Aim Awards. About his academic achievement, more than all these, I would like to say he was one of our best postgraduate students as a MD. And now coming to the non-academic side, he has a passion for directing the movies. Recently, all of you would have heard about the movie. Many of you would have seen Premam Pujyam movie, which was directed by him, for which he has received several awards. Premam Pujyam was a movie which was well appreciated by the medical fraternity and all the general public. The Times Icon Award and Chanda Navana Critics Award for Best Director. Very first movie he has directed, for which he has received this award. And he was also awarded with the Vishwa Manava Award from Dubai Karnataka Press Council. Recently has awarded doctorate for film creativity in Indonesia, Bali. So that is what he is into, academic as well as non-academic front. He has achieved so many awards with this young age, and he is going to enlighten us on the subject TIA and what is new. As we all know, the TIA, the definition has changed from those days. From that time, 24 hours, it has gone to tissue perfusion. So he is going to update us on TIA. Apart from this, I would like to invite all of you for coming Sunday, day-long CME program on hematology. Many of you have registered, I believe, and those who have not registered, please come and have a spot registration and participate. And another event is tomorrow. Our state IMA President, Dr. Shivakumar Lakul, will be visiting the branch in his official capacity as Karnataka State IMA President, along with the Vice President, Dr. Prasanna Shankar, and Divisional Coordinator, Dr. Geeta Doppa, District Coordinator, Dr. Sadananda Pujari. So they will be here, and Sunday's program, Dr. Shivakumar Lakul, President, will be the chief guest. Along with us, we have Dr. Unnikrishnan, Dean of KMC, as guest of honor, and Dr. Sagir Siddiqui, CEO of Manipala Health MHEL. So please do join us for these meetings and make this program very successful. Over to Dr. Raghavendra for your lecture on TIA.
Very less crowd. I was expecting box office house full, but so I don't feel bad because my wife only didn't come today. She was getting ready. Then she asked who is the speaker. I said myself. Then she cancelled it and she said, okay, doesn't matter. We will keep talking anyway at home, she said. So coming to the topic, first of all, I'm very happy because I am in front of my teachers, my seniors, my colleagues, and some of my students are here. It's a nice journey to see. When I was a student, I was presenting in front of my teachers, and again I'm presenting in front of my teachers only. That will never change. So actually I wanted to call IG Bhatt sir, but I was scared. You know why? Every Thursday I used to call him for I have a case presentation. So he used to give B+, never ever B+. So today I didn't call him, I was scared, but he came. So nice. And he's sitting in front, I'm sure he'll find mistakes in me today. So very nice. Chakrapani sir is there, VRP sir is there, Archie sir is there, and Venugopal sir is there. All my teachers are here, and Damodar Shani sir is there, and my Dean JP Allo sir is there. So nice to see all my teachers here. So today's topic, so before going to that, I want to tell something about IMA talks, because I feel IMA is the greatest platform than any other platform. Why? Because if you see, the common thing about all of us is MBBS, honestly. So we are in MBBS level, rest is all division to the super specialty and end branches. So usually when we go for a API meet, we have medicine and super specialty of medicine, cardiology, neurology, nephrology, but all will be based on medicine. And when you go to neurology conference, it will be only high level, talking at the receptor level, that, this and all. But when you come to IMA, it's very nice to know that we are all at MBBS level. Then even if it is a dermatology conference is going on, or oncology going on, or any cardiology is going on, as a MBBS, I always, when I sit here, whenever I get chance I come here, I always think what I can grasp as an MBBS student. And as a family physician, to my family, extended family, friends, how can I guide them? Even a gynecology conference is going on, I may not understand everything about that, high level of those things. But definitely, if my family members, extended family, they don't know I'm a neurologist. For them, I'm a doctor. So when they call and ask, this is the problem, at least I can guide them. So this IMA platform, I want to keep it so simple. Basically, for the students are there back, and to discuss among our colleagues and seniors to say that what has to be done. And here, no point in me talking about point trial, samples trial, NACID trial, Thales study, express study, freedom study, double antiplatelet, triple antiplatelet, that regimen, this regimen. No, that is not my point of discussion at all here. That is anyway available. But today's discussion is what to pick up and what not to miss at the family level as a family physician. That is my main aim here. Otherwise, I can speak diffusion, perfusion, mismatch, bold, gold, a functional MRA. There is no point. So, and most of the time I used to come for dinner, honestly speaking. So that also you should keep in mind. So let us start our discussion for today. So today's today's topic is all about TIA, transient ischemic attack. There's a great saying in neurology that you know stroke, you know neurology. But I say, you know TIA, you know stroke. So no TIA, no stroke, no neurology. So this is a basic principle that we must know TIA first to know stroke. And you should know stroke to know what is neurology. Regarding the famous statement, learn neurology. I always keep telling this till my students get bored of that. Learn neurology stroke by stroke. Who said this? Miller Fisher and Kaplan, the great two neurologists. Why they said this? Learn neurology stroke by stroke doesn't mean that you have to wait a patient to develop stroke to learn neurology. The intention of these two great authors, when they mention learn neurology stroke by stroke, is to learn neurology when every stroke comes to you, to know the territories, to know the MCA territory, ACA territory, PCA territory, circle of Willis, and to know the mechanism of stroke, whether it is hemorrhagic stroke or ischemic stroke, whether it is thrombotic stroke, embolic stroke, artery to artery embolism, or it is cardioembolism. That is the intention, so that we can prevent future strokes. So learn neurology stroke by stroke is just to understand the neuroanatomy, pathophysiology of stroke, so that we can prevent next stroke. Kaplan, a living legend, he beautifully describes, I request all the postgraduates to read at least first 100 to 150 pages of Kaplan, even at the MBBS level, forget DM level, MBBS level, because he describes the whole brain into two halves, left, right, and a hose pipe and a water tank, that is heart. You know tank, you know pipes, you know two halves, that's it. You will understand stroke very clearly. How nicely he explains what happens if pipe is blocked, that is because of atherosclerosis. What happens if heart tank has some problem, stasis, Virchow's triad coming into picture. And what happens in the house. Problem is within the house or problem is coming outside the house. So those beautiful description was given by Kaplan. So that means you must learn neurology stroke by stroke. But there is another famous statement, earn neurology TIA by TIA. Who said this? Myself. Why I am telling this point? Because stroke once happened, it is all about what you will do. But you want to prevent those stroke, that means you must know TIA, because prevention is always better than stroke. Definitely better than cure. Now you see here, why we should know TIA. And unfortunately, now also the word we use is CVA. Not CVA by CVA. No more CVA. Don't ever use the word CVA. If you use you see American Stroke Association Heart Association, European Stroke Organization, they clearly mention stroke. Why not CVA? Now what exactly is CVA? Is an accident. What exactly is accident? Which happens suddenly, either by your mistake or somebody else's mistake. Correct? But how can we call stroke as a CVA? You smoke, you drink, you don't control sugar, you don't control BP, you don't control cholesterol, you have a sedentary lifestyle, you have abdominal obesity, now you can tuck inside, abdominal obesity, and we take a lot of stress, and because of which atherosclerosis is happening in our blood vessels every day since first decade, second decade, third decade, 50%, 60%, 70%, 90%. Then one day, when there is a complete block, we call it as accident. So CVA is not an accident, it's a well-planned incident, and we should not call it a CVA, it should be called as stroke, nothing but stroke. So stop calling writing diagnosis as CVA anymore. It is happening since decades, since ages, but we are not taking care of that. So that is a moral of the story. Now, today in IMA meet, on behalf of all the neurologists in the world, in front of IMA President, Secretary, Treasurer, I want to protest in IMA meet today that why this partiality, why towards neurology? Why? God shows no partiality, but why we people are showing partiality? A patient comes to you with a chest pain, breathlessness, little chest discomfort, sweating, even if it is heart attack or no heart attack, whether angina or no angina, even if it is a gastritis, we get so scared. Everybody, from the patient to the family members to the hospital and the doctors, everybody, ECG is done, echo is done, cardiac marker is done, if it is abnormal, even angio is done. So nice. Why? Because that is unstable angina. If you don't treat, this unstable angina will become myocardial infarction. I'm not at all sad. I'm very happy with the scare you have for heart attack. But when it comes to brain attack, even a patient comes and tells to you that had a slurring of speech, now completely recovered. What you will do? For us, one CT head and one aspirin. Why? Why this discrimination? Is it because my dog is dog and your dog is Tommy? A famous song is there by this lady. Why? If unstable angina is a harbinger of myocardial infarction, then TIA is the harbinger of stroke. Please give the same importance, weightage, respect, fear for TIA as much as unstable angina. But still it's not happening. One CT, normal, aspirin, go. Why? Maybe I found out the reason, maybe because we all feel heart is very, very important, because we fall in love because of our heart. I don't know that. But for your information, it takes only 6 to 8 minutes to fall in love, and it is because of brain, it seems, and not because of heart. Studies have shown. But still, we care about heart, but not about the brain. So I always say to my students, anything that happens sudden in neurology is stroke. Including if someone says, sir, I'm in love, kindly get MRI done. He may be having a stroke. Possibility in thalamai, possible. Okay, so this should be the importance. Sudden means neurology stroke. Sudden, something. We should never say it's okay. So today's topic is harbinger of stroke, that is TIA. What exactly is a stroke? Stroke is nothing but sudden neurological dysfunction caused by focal, brain, spinal cord or retinal ischemia because of acute infarction. Correct? Then what is TIA? Very simple. It is a transient, brief, episodic neurological dysfunction caused by same focal, brain, spinal cord and or retinal ischemia without acute infarction. But it should be transient. How transient? It should resolve within 24 hours. So it should resolve by definition, transient. That's why it is not stroke. If it persists, it's stroke. But my question is, why should I wait till 24 hours? Somebody is having slurring of speech, weakness in one side. I'll tell, don't worry, you don't have stroke. It may be still a TIA. Sit here. 1 hour, 2nd hour, 5th hour, 10th hour, 23rd hour, 24th hour. Yes, in fact, has happened. I'm so sorry. You are not TIA. It's a stroke. We can't do that. Then why this definition 24 hours? Why should I wait 24 hours when window period itself is 4.5 hours? This was the definition before window period, when before thrombolysis came into picture. So there is no point in waiting for 24 hours to resolve and say this is TIA and not stroke. Correct, no? Because once stroke happens, you may not able to do anything. But if it is TIA, we can prevent stroke. So should I wait till 24 hours? No. Should I miss window period? No, not at all. Then should I thrombolyze TIA? What to do now? By definition, TIA is TIA until he is at home. But once he comes to you, even within half an hour, 1 hour, 2 hours, with a deficit, it is a stroke for you. You cannot say it may resolve in another half an hour. And if you do CT scan, if there is no hemorrhage and even no infarct is seen, you can thrombolyze the patient considering him as a window period. So anybody comes to you with a deficit, score more than 5, within 25, NHS score, and CT scan shows no bleed or large infarct, you can thrombolyze. You may say, did I thrombolyze a TIA? He would have recovered another 15 minutes, 20 minutes. We can't take a chance, because once stroke happens, disability may be permanent. It will be because of this reason. But 99.99%, none of our neurologists have thrombolyzed TIA so far. Because whenever we thought it's a stroke window period thrombolyze, next day in MRI we have seen at least a small dot. That means most of the TIA will resolve. Most of the TIA will resolve within few minutes to maximum hour. That means patient gets ready along with the family members. By the time he reach hospital, by the time TIA will be resolved. Rather, most of the patient comes to our OPD and tell that I had a slurring of speech. Luckily, within 5 minutes, 10 minutes, it got resolved. So hardly we have seen anybody with a TIA coming to hospital see like that. But even if he comes to you with a deficit, you can't imagine it may be a TIA. You should treat like a stroke. But almost all patients of TIA is given at the history level, not at the deficit level, because by the time they come to you, either they had a 2-3 TIAs which they have ignored because they are scared to tell that had a slurring of speech in front of family members. They feel it is a stigma, God's curse. Heart, they are very scared. Engine, they will come, but brain, if it disappears, they won't even tell to family members. I will not tell. So that stigma, that fear is always there, because of which most of the TIA, they don't come to you at the time of presentation. It will be at the historical level. So because of which, when they come to us with a history, we should diagnose as a TIA. Now, next question. Can I thrombolyze TIA even if it is completely recovered? Say morning he had a half an hour hemiparesis, recovered, he comes to you. You want to thrombolyze? No. Why? Because when you don't thrombolyze minor stroke only, NHS score less than 5, so where is the question of thrombolyzing TIA? So TIA as such history, it comes to you with a no deficit, no thrombolysis. Patient comes to you with a minor stroke less than score 5, no thrombolysis. Because anyway it is a minor stroke, the benefit versus risk ratio is too much. But score more than 5, up to 25, you can thrombolyze, because there is the benefit of thrombolysis. TIA, no. Luckily most of TIA resolve within minutes to hour. Rather, more than 10 minutes of TIA, it's a bad sign. It's a high risk TIA. More than 10 minutes, somebody says 10 minutes I had slurring of speech, imbalance, hemiparesis recovered. That more than 10 minutes is not a good sign. He has a high risk for stroke. So this is very, very important. Luckily, the definition has changed. A brief episode of neurological dysfunction caused by focal brain or retinal ischemia with clinical symptoms typically lasting less than 1 hour without evidence of acute infarction is the definition by TIA working group published in NEGM. This is the beautiful definition. I really am very happy with that because 1 hour only they have kept. That means you will not miss window period. Anybody comes beyond 1 hour, you can treat like a stroke, and even you can thrombolize if your score is more than 5. Even if you don't have MRI, even if there was no infarct next day in MRI, you will never be penalized or punished for a thrombolizing TIA if it is beyond 1 hour. And that means you can wait up to 1 hour. Definitely can wait up to 1 hour and get investigations done. It will take some time for you to get CT scan and MRI. Now why this without evidence of acute infarction? Because once there is a single dot in MRI, that is a stroke. And you cannot neglect a small dot, chalta hai, no. Even a small dot, lacunar stroke, it's a minor stroke, is a harbinger of major stroke. So if TIA you neglect, it may end up in minor stroke or major stroke. If you neglect minor stroke, it can end up in major stroke. That means you must do MRI brain when you suspect a TIA. CT scan was just done for a thrombolysis purpose when the facility is not available, when MRI can take some time. You can thrombolize, not waiting for MRI. But if it is a TIA, completely resolved, he comes and sits in front of you, tells, I have got a deficit, now recovered completely, kindly consider MRI and not CT scan. Why? Because CT scan can miss small infarct, where MRI usually will not miss. Unless you are thrombolizing. Otherwise, go ahead with MRI and get in. That is one reason. So you can't call anybody, you can't say this patient is having TIA without doing MRI brain. You must do MRI, then only you should say if MRI is normal, then only we can say it is TIA. Why this point is important? Because when a MRI itself can miss infarct, what to speak about CT scan? There is a possibility that MRI brain can sometimes miss a small infarct, particularly when infarct is in the posterior circulation, brain stem, cerebellum, pons, medulla. That's the reason when you ask for a stroke profile MRI, if you are suspecting a posterior circulation stroke, kindly mention MRI brain stroke profile. If possible, thin section brain stem. Thin section brain stem. That means you can have a stroke. That is called MR negative stroke. Important to take home message for all the students back there. If a patient comes to you with a hemiparesis, completely resolved, if MRI shows small infarct, though clinically it was a TIA, no deficit at all, including pronator drift also is not there, label him as a stroke. Clinically TIA, but radiologically stroke. That is a point number 1. Stroke is a stroke. That's it, radiological or clinical. Even clinical symptoms completely resolved, no deficit at all. Point number 2, even patient has got persistent minimal deficits, not improved completely, and if MRI is normal, then also he is a stroke. Because of this reason, as MRI posterior circulation can miss a small dot. That's called MR negative stroke. So ultimately, clinical deficit persists, it's a stroke. Clinically, the clinical deficit resolves. If radiologically even a dot is there correlating clinically, then also it's a stroke. So MRI is a must to see the dot. That is very, very important and not to miss. So kindly get MRI done and not a CT scan. Unless you are thrombolizing, you don't have facility, you don't want to waste time. Now what are do's and don'ts in neurology for TIA? First thing to do in TIA is do diagnose it as a TIA. And first don't in a TIA is don't miss the TIA. We have no rights to miss TIA, seriously. You may overdiagnose, but you should never ever miss TIA. Because statistic states 80% of the TIA will end up in stroke if you don't diagnose. 80% of the TIA, if you neglect, it may end up in becoming stroke. 20 to 30% of the stroke, if you ask history, they had a TIA. And 10% of the recurrent strokes had TIA. See how much neglect is happening at the patient level, at the family level, and even at our level, honestly speaking. So you must not miss TIA, because 80% is a very big number. of TIA, if you don't work up, they will come back to you with a stroke for sure. 80% is a very big number. American Heart Association, Stroke Association, ESO mentioned MRI as the most important protocol for stroke and TIA. Why? Because the so-called TIA by history and CT scan, when the MRI was done, 50 to 60% of them had a stroke in MRI. That means so-called TIA became stroke just because MRI was done. So 50 to 60% of TIA automatically became stroke when MRI was done. Imagine the importance of MRI and how much CT scan was missing. Most important is TIA mimics. Very sad to know that, or very important to know that 50% of the referral case to us as a TIA is actually not TIA. They were TIA mimic. Now this is very, very important. Everybody knows Talaivar, superstar, Rajini sir is there, and we also know he is mimic. Now, what is the difference you all know? Same thing here. Sometimes a disease is something else, but they come to you mimicking a stroke or TIA. Yes, who is that? I still remember when one of my postgraduate, very enthusiastic. When I joined, he was also enthusiastic. When I was also enthusiastic, 2 o'clock in the morning, 2 a.m. in the morning, night, he calls me, sir, acute ischemic stroke, window period, NHS score 11, no contraindication, BP is 160/100. It was 185, I given labetalol and BP has come down. Shall I open the bottle, sir? I said, wait. What is the sugar? Sir, sugar is not a diabetic, sir. Shall I open the bottle, sir? Wait, man, relax. Raghavendra B.S, sir, 1 minute, sorry. Sir, I'll call you back. No, I said, I will hold. I'm not sleeping. You call me. I am hold. Just check GRBS. So he calls sister. GRBS is checked. Right hemiparesis. GRBS done, 46. Sir, but patient is having no sweating, sir. Patient is not have giddiness. Totally fine, sir. I said, open the bottle, but dextrose bottle, not the actylysis injection or thrombolysis injection. Give him dextrose. Dextrose given. I said, call me back after a few minutes. Completely lifted his hand and leg. Sir, sorry, sir. Now NHS score is normal. So this is TIA mimic or stroke mimic. Be careful before thrombolizing or before giving antiplatelet statins. Be careful about this TIA mimics or stroke mimics. 3 people are notorious for causing TIA mimics. One is hypoglycemia. Very interesting. Hypoglycemia and hyperglycemia are the 2 important conditions in neurology which can cause focal neurological deficits or focal seizures. Whereas all other metabolic derangements like hyponatremia, hypocalcemia and all, they cause generalized weakness or generalized seizures. That is very interesting. Hypo and hyperglycemia. So kindly check sugar before labeling TIA or stroke. Post-ictal TOTS paralysis. How many seizure patients have come to us with one-sided weakness, and once post-ictal confusion is over, TOTS paralysis is over, they lifted the hand. Be careful. Please take the history of seizure. He might be having a scar seizure, focal seizure, TOTS paralysis. He will recover for sure. Migraine. How many complicated migraine, hemiplegic migraine have come to us? We are about to thrombolize, but the history is so classical, associated with a headache, peak of a headache because of cortical spreading depression, vasoconstriction, vasodilatation, whatever. But hemiplegia has happened. Then only by giving analgesics and anti-migraine medications, all these episodes never happened later. So this is very, very important. Apart from this, particularly posterior circulation stroke, we always tend to be very scared. Vertigo, syncope, pre-syncope, blackout. My God, how many syncope have come, referred as TIA. But it was just a syncope. Upright posture, against gravity, sweating, preceding giddiness, blackout. Kindly refer to Dr. Manish Rai to do head-up tilt table test. If it is a vasovagal syncope, if he elderly, kindly rule out arrhythmogenic syncope. But these are the mimics we often miss. Anybody losing consciousness is not stroke. So be careful, but don't miss these 3 people: hypoglycemia, TOTS paralysis and complicated migraine. We ourselves published this case. a complicated migraine of classic migraine, common migraine, hemiplegic migraine, and disappearing with medications. So we should be very careful. Sometimes status migrainous can even cause infarct, stroke. Now this is one side of the story. Even if you overtreat TIA mimic, pardonable. Say you give necospirin, clopidogrel, chalta hai. Of course, giving thrombolysis is not justified, but nevertheless, it can be in neurology, chameleons. Actually, what it means, patient has TIA, but manifestation is not like TIA, and he will go to some other specialty. And you will miss, and later deficit can be permanent. Because of this reason, kindly know what is chameleons. With neologism, jargon speech and all those things, they may go to psychiatrist first, honestly. And I should appreciate many of psychiatry postgraduates. They called up, sir, he never had a psychiatric illness in the past, but today morning onwards he's talking totally irrelevantly, fluently. I ask something, he speaks something. That could be a Wernicke's aphasia, temporal lobe infarct, but it was sudden onset. Never had a psychiatric illness. But no deficits, no motor deficits, no slurring of speech, no dysarthria, no hemiparesis, no ataxia. Who will suspect stroke? He will never come to neurologist first. So this is our family, I am a family, our colleagues. Even not being a physician, non-neurological branches probably should take home message that these people kindly refer immediately because they can be in window period. They can be in window period to thrombolyze. Recently, 1 week back, our postgraduate, a lady came and sat. Herself is telling, I'm totally fine, but I am having memory problem. When? Since yesterday. They may go to psychiatrist again because it's a dementia. Memory problem is dementia, but no dementia will happen suddenly. And that sudden onset dementia, memory impairment can be a stroke. Can be a stroke. Particularly when infarct is in thalami. And our postgraduate was so good, MRI was done and MRI showed thalamic infarct. Patient admitted, treated like a stroke. So this is called strategically placed infarct. Vascular cognitive impairment. TIA chameleon. Doesn't behave like a stroke at all, doesn't behave like a TIA at all. So dementia and Wernicke's aphasia are two important TIA chameleons. We should not miss. Sometimes when there is occlusion of the carotid artery is 90%. When he gets up, typically described by Kaplan, beautiful. I have seen 1 or 2 cases in Jaipur itself. When they get up or then do their neck like they tilt their neck, extend their neck, they get jerk-like movement of the opposite side. If 90% block is here, jerky-like movements, and this is called limb shaking TIA, and unfortunately will be diagnosed as seizures. Levetiracetam, sodium alpurate, all given. By the time you diagnose, that 90 becomes 100, you end up in having a hemiplegia. So please know this limb shaking TIA as mimicking as seizure. Thalamic infarct mimicking like a dementia, and Wernicke's aphasia going to psychiatric illness. So never miss this mimics as well as chameleons. Now this I put purposefully because I unfortunately that PG took away everything and went, so I have to put this from Google only. I had a reference from psychiatry. I was going for rounds and I got a call saying that I was very happy, psychiatrist called me for that. I went, what is this? So the PG was explaining me, it is 2014, psychiatry PG posted under neurology. Sir, we don't know, sir, he tried to commit suicide by cutting his radial artery. I said, for me, why, man? No, sir, they want to rule out a neurological cause, organicity. Yeah, come, I was talking. Patient is fine, young chap, newly married, 5 days. I'm not exaggerating, 5 days of marriage. Wife is there only, both hand mehendi is there. So I said, what happened? He's totally fine, talking nicely. The history is, I said, what happened, ma? No, sir, morning we were having breakfast. I was cutting apple for him and he took a knife, took piece of bread, took jam, and he was doing like this. He looked at me like that. I got scared. He took knife like that and he cut his artery. He wanted to commit suicide. And she's worried because everybody is blaming her. Within 4 days of marriage, he's committing suicide, trying to commit suicide. Is the main issue now. Then I told my PG, see, after marriage, all men at some point of time, they will think of committing suicide, for sure. Sure, nobody will say no for that. But this is too much. Within 4 days, this is a honeymoon period. Definitely, this can't be suicide. Sudden onset, he looked and cut. Stroke, get an MRI done. MRI showed frontal lobe infarct. Personality only changed. Infarct of frontal lobe. His personality changed, he cut. And I gave all the data to him. I said, publish this article. Patient also disappeared. PG also disappeared. I don't know, publication never happened. She went back to North India. So what I want to say is that, see, sudden onset suicidal attack could be a stroke. It was mimicking like a suicide. But it is never a suicide. It was a stroke, orbitofrontal cortex infarct. So we should be very careful about this. So one more thing, we neurologists or all physicians, all doctors, we receive a lot of love letters. For us, these are the love letters, that's the referral letters. But one problem is that when they write a love letter and send to us, unfortunately they will write diagnosis there. Query TIA, query MI, query fracture, query everything. And that is the biggest problem. You read that and our PG also tells her TIA, all those things. Never ever do that. Kindly, you see the name who sent, that's it, regards, last name, that's all. Then close the paper and don't even read. It's my sincere request. Because there will be 3 versions. PG version, that referral doctor's version, and the truth. And the truth is only between you and patient. So kindly don't believe the letter. Respect the letter, call back and say whatever you want to say. But you must take proper history, quick history and examination. Like stroke, we have a TIA also can be classified as a large vessel, small vessel, cryptogenic, embolic source of unknown origin. And this classification I didn't like. They classified again into low risk TIA, high risk TIA, moderate risk, severe risk, very high risk. My question is, all TIAs are risk only, high risk only. The moment you use the word low risk, again you'll become silent, you will become neglected, you will think, okay, let me calm down, it is a low risk TIA. No. A low risk TIA can have a major stroke and high risk TIA can have only minor stroke. Never ever underestimate this TIA. So all TIAs are high risk unless proved otherwise. But still, this classification was done only to decide what should be the treatment. Single antiplatelet, double antiplatelet, what? Anticoagulation, that's the only reason. Otherwise, all TIAs are high risk. Kindly go through this ABCD, not a movie. ABCD is an important score for calculating the risk for TIA. Medicine, for that matter, neurology. I confidently tell this. Still, now also, till date, our diagnosis is based on chief complaints, history, presenting illness, and examination. I always fight with my wife. You talk in markers, but we take proper history and examination. So why? Because in neurology, if you do simply an MRI, you can't come to a conclusion unless you know what to see. That is very, very important. Look at this, ABCD2. What is A? Age. Age more than 60, give 1 point. B, blood pressure more than 160/90, give another point. D, diabetes, give another point. Duration, anything more than 60 minutes of symptoms, TIA, give 2 points. If less than 60 minutes, say 10 to 59 minutes, give 1 point. C, for clinical symptoms, slurring of speech, give 1 point. Hemiparesis, give 2 points. Now you tell me, where is the investigation here? That means in spite of all the big, thrombolysis, retriever, mechanical thrombectomy, MRI, function, everything done, still we are using ABCD2 based on history, age, clinical duration, symptoms, diabetes, that's all. That is the importance of medicine, particularly neurology. Now also history and examination matters. So I always tell my postgraduate, in neurology, investigations are done to see whether machines are working or not. That's it. You should say, see, I diagnosed thalamic infarct, there is a thalamic infarct. I diagnosed like L5S1 radiculopathy, MRI showing a disc prolapse at L5S1 because ankle jerk is absent, SLRT is positive. That is the story. Now, if a patient develops two TIA attack in 1 week, it's called dual TIA. Give one more score. Score is 2 point extra. Till 7 score is called ABCD 3. Dual TIA within 1 week of index attack. Now you want to add investigation, do angio. And if imaging shows more than 50% blockage of carotid artery or large artery, you give another 2 points. Now what is the score? Score is 7 for ABCD 2. If the moment you add D, 3, it becomes 9. The moment you add I, it becomes 11. And anybody having score between up to 3 is called low risk TIA. 4 and 5, moderate risk. 6 and 7, high risk. Above 7, very high risk. Now this, all postgraduates should write in their case sheet when they come with TIA, my ABCD score is this. Why it is important, I'll come to it later. Workup. In spite of all this Akashwani, all Arogya Deepa, all these talks we are giving neurologists, everybody is still slow. That's the reason they made a mnemonic, fast. Anybody having face drooping, weakness, difficulty in speech, time to call. Still so everybody is slow. That's why they come up with a new slogan. Don't be fast, be fast. B for balance, I for eye signs. Even that is there. That is also part of stroke. Only facial drooping, they're all, deceased don't read books. Stroke, patients don't, read and come. Deceased don't read books. We should know even balance can be stroke. Eye signs can be stroke. That is important. Don't waste time. This is not a time. I know, I only told take history properly. Imagine patient comes with a TIA asking about his grandfather, about his wedding anniversary, how many boyfriends, girlfriends he had. This is not a time. Quick history, quick examination, quick imaging, then probably you can take detailed history later. How fast we should work up TIA patients? 4 hours, within 4 hours. Honestly speaking, 24 hours. But again, people neglect. So we have kept it 4 hours now. At least within 24 hours, you should be able to do all the relevant investigations for TIA. Quick history, quick examination, rule out TIA mimic, and don't miss chameleons. Clear? Brain imaging. MRI, MRI, MRI. With angio. Very, very unfortunate thing. I'm very sorry to say. Now also, stroke patient come to us only with MRI brain without angio. Why? If heart needs an angio to know the heart issue, why not angio to know the brain issue? Why only brain? Why are you not seeing the pipes? Why only house? Please, angio is a must. If MRI is not available, then what to do? CT scan with the CT angio. Some studies even have shown that CT angio is superior to MRI angio. Because MR angio cannot differentiate between complete occlusion and near complete occlusion, whereas CT angio can differentiate between complete to near complete occlusion. Doppler, when angio is done, why Doppler? Doppler has its own value, plaque morphology, intimal thickness. Echo, please trouble your cardiologist. Please. ECG echo is a must to look for atrial fibrillation, to look for all the valvular heart disease, EF, etc. is a must because it's going to give a lot of clues. And echo, transthoracic and transesophageal. Very, very important. Never ever miss any of these investigations, and all this has to be done within 4 hours or at least by 24 hours. At least transthoracic echo, up to transthoracic echo if you can't do TE. See this patient, CT scan, patient came with a stroke. What you can see, CT looks normal, na? Same patient, see, such a large infarct. See, what is the difference between CT and MRI? This is the difference. Shock, see, angio. This is basilar artery, this is left ICA, where is right ICA? It's missing. All this while you are surviving through left ICA, left MCA, left ACOM, then circle of Will is coming to right MCA. But now he came with stroke because there is one more problem happened in MCA. So that means without doing angio, you will never come to know how much is the block. and how he was surviving all this while, and one more occlusion somewhere above, gone. So that is the moral of the story. You must do angio with scan, CT angio or at least MR angio or at least CT with CT angio. Never ever do just CT scan, never ever do just MRI. Is very clear? Heart and brain are the best friends, or I can say best couple. See the mehendi? They should be like this. Of course, neurology and oncology also make good couple. But nothing can match neurology and cardiology for sure. When you say couple, blame game, fights will be there. So let us fight. Manish is my best friend. He's my neighbor also. We stay in the same lane. So it is very important. My professor Ashok Pangade used to say, he's no more, with his best cardiology friend during tea break. Cardiology friend used to be there next to him. Raghavendra, always remember, any patient comes to you with a stroke, having a cardiac illness, either valvular AF, non-valvular AF, rheumatic heart disease, low ejection fraction, less than 35%, PFO, even mitral valve prolapse more than 2 mm descent, blame on cardiologist. It is cardioembolic stroke unless proved otherwise. That was such a beautiful dialogue told by him. I am still following it. Anybody with cardiac illness come to a stroke, it is cardioembolic unless proved otherwise. And particularly patient is stroke in young. Never ever miss this. Because textbooks clearly states 40% of the stroke in young is cardioembolic stroke because of occult cardiopathy. Occult cardiopathy. No point in simply doing MRI and keeping quiet. Young patient means kindly work up. Don't be happy with ECG. Don't be happy with 2D echo. Bring the cardiologist. Request, beg for transesophageal echo. That is normal. Go for Holter monitoring. That is normal. Give reference to Manish Rai. Get loop recording. ELR. 1 week, 2 week, 1 month if you are very sure that I am dealing with a case of cardioembolic stroke. But before that you suspect. When a neurologist can categorically say it is cardioembolic stroke, number 1, abrupt onset, rapid recovery. That itself should tell, yes, I may be dealing with a cardioembolic stroke. If MRI shows more than one territory infarct, anterior circulation, posterior circulation, left hemisphere, right hemisphere, highly suggestive of cardioembolic. Or if he is having AF, low EF, or any valvular heart disease, it is definitely cardioembolic stroke. Look at the causes of TIAs in young. Number 1, RST, prosthetic valve, atrial fibrillation, valvular, non-valvular, PFO, myocardial infarction, mitral valve prolapse. And later only you come to know so many vasculitis, dissection, prothrombotic state, moya, polycythemia. Oh yes. How many polycythemia people have come to us with a TIA? Dr. Prashant will be knowing how many cases we have referred. In that case, TIA, plugging, TIA, then dissolving, stroke. That is very, very important. So, before going to this, kindly rule out this. It's very, very important. And don't miss this. Anybody can diagnose what this is? Apical ballooning. Recently, 2 days back, Manish Rai calls me and tells, Raghu, your patient stroke, large MC infarct, is having apical ballooning. I was shocked. He sent me the video. Takotsubo cardiomyopathy. So, for more information, Takotsubo, kindly log into Premam Pujyam. Thank you. So, that is very important. Never ever miss cardioembolic stroke. Do all the evaluation. Transesophageal echo. Very, very important. Why I am insisting on T in a stroke in young or TA in young? Because when you do 2D echo, you can see ventricular aneurysm dysfunction more better. But rest of all the problems, atrial thrombus, AST, PFO, aneurysm, myxoma can secrete mucin-like substance and can give rise to thrombus elsewhere in the brain, myxoma in the heart. Myxoma is not going to brain. It producing the mucin-like substance can causing hypercoagulable state can go and form thrombus formation there. Not just piece has to go up. So all these vegetations, aortic dissections, all best diagnosed by transesophageal echo. Kindly utilize this. Request cardiologists, they will do. They are not doing because we are not asking. This should be the take-home message for all stroke in young, and whenever you suspect cardioembolic TIA. Now why I was fighting with cardiology postgraduates when I was a DMPG or now also with my colleagues? Why? I still remember my DM days in Jaipur. I had a very good friend of cardiology. I always pressurized to, please do TE. One day he said, today I will prove to you it is not a cardioembolic stroke. I said, okay, bet, treat, done. Then he took with his consultant, transesophageal echo done. Then he said, nothing, no vegetations, no thrombus, no apical clot, but there is left atrial little dilatation. PG looked at me, see, I have proved, because if I do transthoracic echo, you will blame me. You have not done TEE, that's why I missed the clot in the heart. I have done TEE now, where is the clot? Give me the treat. I said, sorry, you should give me the treat. Why? Left atrial dilatation is there. Yeah, but it is empty, man, he said. We used to talk in terms of bullet, and we never used to clot. He said, there is no clot. I said, bullet is there. He said, where is the bullet? Bullet was there. Then where it has gone? It has gone to brain. You're searching for a bullet is already fired, man. And this phenomena is called smoking gun phenomena. Tishka, 10 gun fired. 1 gun fired out of 10. You see the smoke. And that is the gun which is releasing the bullet. So if there is a atrial dilatation, that itself is sufficient for me to blame cardiology to say this is a cardioembolic stroke. And this phenomena officially called as smoking gun phenomena. Cardioembolic stroke. Typically MCA, superior division, because embolus goes directly to the superior division more than inferior division. If there is a hemorrhagic transformation in the brain, favors cardioembolic stroke. Why I tell you later. And more than one territory favors cardioembolic. And that's how, even if TE shows no clot, you must say cardioembolic stroke. Now why this fight happened? Why? This is only because for patient's sake. Because the moment you say it is non-cardiac stroke, non-cardiac TIA, all you have to give is antiplatelet and statins. The moment you blame on heart, cardioembolic TIA, cardioembolic stroke, no use of antiplatelets. You are supposed to use anticoagulation. That's the only reason why we are fighting with our colleagues. For this reason, why we are begging, requesting cardiologists to do TE, Holter, ELR. Because the thrombotic clot formed in situ because of hypertension, diabetes, dyslipidemia, atherosclerosis, narrowing, Vershostria, turbulence causes platelet-rich white clot, hard clot, where only your antiplatelet and statins will work, not your anticoagulation. And giving anticoagulation to these patients will end up in bleed, that's all. Whereas cardioembolic stroke, clot coming from the heart because of ventricular aneurysm, atrial dilatation, because of stasis, Vershostria again, is a red clot, is a soft clot, is a smooth clot. It's a fibrin-rich clot. And it needs anticoagulation and not antiplatelets, because studies clearly shows the white clot is 7 times stronger than red clot. And to break red clot, we need anticoagulation. And to break white clot, we need antiplatelets. For this reason, unnecessarily put antiplatelets for a cardioembolic will end up in bleed without benefit, and will end up in stroke also, embolic stroke. That's the reason. If we have a low risk TIA 0 to 3, single antiplatelet is sufficient. If it is 4 and 5 or above that, please go for dual antiplatelet if it is non-cardiac. That means please use aspirin as well as clopidogrel after giving loading dose of 325 and 300 respectively. Continue dual antiplatelet, DAPT. How long? Some study says 21 days, some study says 3 months. Till 3 months, kindly give DAPT, because beyond 3 months, there is high chance of bleeding now in them also. So 3 months DAPT followed by SAPT in high risk, very high risk TIA. But if it is cardioembolic stroke or hypercoagulable state causing stroke, it is anticoagulation. And important take home message, if it is a valvular heart disease, it has to be warfarin, warfarin, warfarin. But if it is non-valvular AF, cardioembolic but not valvular heart disease, no RHT, you can use dabigatran, you can use apixaban, rivaroxaban, all those things which have come, which I am not going to go in detail about the dosage and studies and trials. But you can use anticoagulation. You must use anticoagulation for cardioembolic. But if it is valvular, warfarin, non-valvular, other anticoagulations. And if patient comes with a TIA, recovered completely, and if you on imaging because of CT angio, MR angio, if shows more than 50% stenosis, kindly get stenting done within 2 weeks, no discussion, within 2 weeks, stenting or carotid endarterectomy. Trouble your neurosurgery colleague or trouble your intervention neuroradiologist and put stent, whichever is convenient for the patient and the consultant, seriously, in the sense availability of the facility. Within 2 weeks, because after 2 weeks if you delay, 50 can become 90, 100% anytime. And TIA can become major stroke anytime. And apart from this, kindly control sugar, BP, cholesterol, exercise, all those intense risk stratification has to be done. Because very unfortunate, I am reading this again, more than 50% of the patients do not receive anticoagulation in cardioembolic TIA and stroke. Even if they receive, 10% of them receive inadequate dose. Rather, unfortunately, they receive antiplatelets. These are the fascinating syndromes which I am not interested. But one important information before concluding I want to tell. Whatever I spoke now on TIA should be copy-paste by the students, I am telling you, to minor stroke. What is minor stroke? Anybody having score less than 5 is minor stroke. Whatever you learnt now for TIA, you should follow same for minor stroke. Because today's minor stroke is tomorrow's major stroke. So investigation and treatment is same for TIA as well as minor stroke. But the moment he crosses score more than 5, major stroke, kindly do thrombolysis. That is not a discussion for today, we will do some other day. But within 3 hours, above 80 years, thrombolysis. Within 4.5 hours, below 80 years, thrombolysis. Beyond 4.5 hours, up to 6 to 8 hours, go for thrombectomy. Previously used to use altiplase 0.9 milligram per kg body weight, but small problem. You have to give bolus, then you have to keep 1 hour infusion. But luckily, now 10 hectoplase has come. Not neurologists are using now. Previously, cardiologists have already used. All you have to give is 0.2 milligram per kg, 1 bolus, IV bolus in casualty. Thrombolysis is over. But you can bridge this with a thrombectomy, or directly you can go for thrombectomy, use the retriever and remove thrombus. So all minor stroke should be treated like TIA. I can see a lot of TIA symptoms there among my students. One of my close fellow is not only having a drooping of angle of mouth, I can see drooling of saliva also. This is a dinner time. I want to wind up and before somebody gets minor stroke or major stroke. Thank you so much for your patient hearing. If you have any doubts, we'll discuss during our dinner time. If I know, I will answer. If I don't know, I'll read. I'll definitely answer. I will WhatsApp you people. Thank you so much.
Thank you very much, sir. For taking time from his busy schedule and enlightening us, I would request Dr. Venugopal to hand over a small token of appreciation to Dr. Raghavendra.
A plus plus plus. Thank you.
Excellent talk, Dr. Raghavendra. As you said, this terminology of brain attack, few years ago I heard Dr. Srinivasan from Madurai, a senior most those days a senior neurologist, how heart attack is so popularized, this brain attack. But nowadays we don't see that brain attack terminology which is not being used. That is a reason for partiality, I think. The cardiologist get more attention rather than the neurologist. With due respect to our cardiologist, Dr. Manish, and who is there. Now, this cognitive dysfunction, I have seen several patients who undergo this angiogram, coronary angiogram and bypass surgery, including myself. I had this dysfunction of nominal aphasia. For some time it lasted and then I recovered from that. Because these manipulations also could cause minor showers of embolism, micro-infarction probably, which is less recognized. It is only the neurologists who recognize this kind of things probably. And this is another thing where you can call this as a minor stroke or something like that. Yeah.
So that's why in some centers they use transcranial Doppler. Following these procedures and all, they will do transcranial Doppler because they come to know this small emboli, microemboli going to brain. It produces a sound. We call it as hits. More than 50 per hour is very, very significant. So transcranial Doppler is a new modality. There are some fellowship on this only. It really helps for two reasons. One is diagnosing the embolization. Hits, tap, tap, tap sound will be coming, and that is one. And transcranial Doppler itself is used for a treatment also to break the clot. If they find MCA, there is a clot, they can use this TCD to break the clot. So as you said, sir, during the manipulation of following surgery, particularly cardiothoracic surgery, this calcification or small emboli can go up. And that's the reason. And I really want to thank all my cardiologists, particularly Manish, I always, because whenever I asked for arrhythmia workup, and transesophageal echo he has done, and many times he calls me and tells there is apical clot, there is a vegetation, there is a arrhythmia. So it's very nice to know, because our treatment we are satisfied. Confidently we can put anticoagulation rather than simply keeping antiplatelets for life.
I think as I said about the PFO, I think something which is not diagnosed with the, even I think transesophageal echo can miss a PFO. So, yeah, so possibly those patients we have to put on anticoagulations only. I think Manish also would agree with that if you suspect.
Manish, PFO means they do some agitated saline contrast.
Unexplained stroke, we always do a TE and give agitated saline. That's bubble contrast echo. We can do it with TT also to pick up a PFO, but it's not always easy, especially when doing a TE, because you have to coordinate with the Valsalva. So another thing is, there are multiple other things in the heart, just like LA dilatation, which are associated with the stroke. So another thing is something called as the IAS aneurysm, intraatrial septal aneurysm. So sometimes you need not have a PFO. You can just have a septal bulge. And it's shown that people with cryptogenic stroke sometimes have this IAS aneurysm. So if you have an unexplained stroke and a large sac in the IAS aneurysm, you are still justified in considering anticoagulation, even if you do not prove an PFO.
The cardiologist attributed to atmospheric pollution. Would you like to, what is your comment? If the concurrence in young stroke or stroke, your comment about, they attributed the endothelial dysfunction related to cytokine release due to the atmospheric pollution. Because our major metro cities are hugely polluted, top ranking in the entire world, Delhi, Chennai, Mumbai and Calcutta. The cardiologist there, I don't know Manish's opinion there. What you would like to, in the contemporary, in the young stroke, in the atmospheric pollution and young stroke?
Which cause endothelial dysfunction, activating cytokines, platelet aggregation, atherosclerosis. This is called premature atherosclerosis. So they found because all these toxins, they are more prone for a premature atherosclerosis. One side is cardioembolic stroke in young. The rest of 35 to 40% of the patient is like elderly only because of atherosclerosis, but they are called as premature atherosclerosis. For that, their lifestyle, junk foods and toxins, poisons, all these things also matter. And for the youngsters who are here, I want to tell why this low risk TIA, high risk TIA was done, because it is said that within next 48 hours, if a low risk TIA is not taken care, the chance of stroke is 1%. But 4 to 6 is a score, that is high score, moderate score. The chance of stroke in next 48 hours is 4.1%. And if it crosses more than 6, the chance of stroke in the next 48 hours is almost 8 to 10%. And after 90 days, it is 18%. So there is no chance, no way we can miss TIA, we should not miss TIA for this statistical reason.
Sir, a nice lecture, sir. I just want to, as you are telling in the class, the word should be CVA, CVA should be replaced by TAA. But still, I think All the hospitals they are using, if I go to ICU, what is the diagnosis? Sir, left side is CVA. So I think slowly this will, all the neurologists should put a pressure on all medicine, even medicine people only they are telling, what is the diagnosis? CVA. So CVA what is become so common, I think it is not that easily can be replaced by TAA.
Correct, sir. Correct.
And your lecture is very nice. A lot of movie pictures I remember my old days.
Thank you, sir. That's true, sir, but slowly all the guidelines are mentioning stroke now.
But still, it will take time. It will take time.
It is not wrong in using, but only thing is the purpose of why I was telling why it should not be used as accident, because of for this take-home message, it was not an accident. It was going on since years and decades. So it is an incident. We should be prevented.
Yeah.
That's the reason.
And I am working in Deralakatte Medical College Hospital. A lot of cardio, heart attack hoardings are there on the way. But for these neurology emergency, for stroke, 1 or 2 also, nowadays I can see few hospitals are putting their hoardings on the highway, like emergency treatment within 4 hours, like that. When compared to cardiology hoardings, these neurology hoardings are less.
Yes, sir. So that's why I was protesting, sir.
Just one slight deviation from the topic, or even though urology is there in neurology, part of urology. Any urological symptoms, these PIA patients can come with sudden episodes of incontinence or anything like that.
That's a wonderful dialogue, I can say. Urology is there within neurology. It is said when somebody comes to you with a bladder, isolated bladder, again the famous dialogue, anybody comes to you with isolated bladder symptoms, it is urological, unless put otherwise, it's urology only. But if patient comes to you with a bladder in association with any other neurological symptoms and signs, then only it is neurourological bladder. It is cortical bladder, uninhibited bladder, whatever bladder we call it as, spastic bladder, 11 bladder, your bladder. But almost all neurological bladder will come with a company it keeps. But if isolated bladder, please trouble him, not me. But most importantly, pontine infarct, very, very important. Pontine micturition center is there, PMC. If there is a clot, patient can come with a sudden retention of bladder. But pons has so many fibers, you cannot miss hemiparesis, quadriparesis. It has so many cranial nuclei, you cannot miss bulbar palsy. But if a small dot is there, exception is always there, in that center, medial nuclei, and that can cause sudden retention. But again, the sudden retention, the sudden word is very important in neurology, and that again clinches towards stroke. Thank you so much. That's called Barrington nucleus, or PMC.
Coming to the end of the meeting, I request Dr. Archit Bulur, Secretary, IMA Mangaluru, to address the gathering.
February, so we had our first executive meeting on the 10th, and then the CME that we had with the Metropolis, that was on 10th. We had the camp which we did in Kanyan, and we've discussed it in the last meeting. It was a very successful camp that we had. And on 24th, we had the gastroenterology CME with Dr. Chandrasekhar and Dr. Santosh, who gave both the medical and the surgical management of GERD. That's what our CME activities. Our regular quizzes continued, though of late I'm seeing that our respondents have come down to 100. In the beginning, we had almost 250 people responding to the quiz. With the latest one, that's this one, which was of last Sunday, we have 120 respondents as of now. March began with the Women's Day, and our women's wing did the first meeting, I think, yesterday. Day before yesterday, the first meeting, which was on women's health and diabetes. Dr. Archana gave a wonderful talk, and that was followed by fashion show which was attended and appreciated. We were not allowed, so I have no personal experience on that, but madam is there, madam, and even Archana told it was wonderful. I can make out from the pictures that Archana shared with me. So Women's Wing has been absolutely active, and they did conduct a lot of other programs also commemorating the Women's Day programs. Today morning I addressed Radio Sarang on flu. Some of our members' achievement, yes, Raghavendra and Dr. Narsimpai won the Global Icon Award in Bangalore for healthcare, and we had one of our lady members who was felicitated at the Berry Mela, as well as Dr. Ashok Shenoy, who is Professor of Pharmacology, had been felicitated by the Indian Society of Clinical Research for the significant contribution for the environment shaping initiatives as ISCR in the annual conference at Delhi. Upcoming events, we have quite a few ones coming up. Just tomorrow we have the President's visit, as well as with his team he is going to be visiting us tomorrow. He is expected to reach Mangaluru by 6 p.m. and 6:30 to 6:45 we will have the press conference that will be occurring at this hall, followed by maybe the talk from the President there. So that is for tomorrow. And on Sunday we have the hematology CME. We have already announced, and I think 157 registrations have occurred for the CME. That's a big number. I thank all the HODs of medicine, pediatrics, pathology from all medical colleges, including Surya, who have encouraged their postgraduates to participate. This is CME accredited CME. 2 hours CME credits from Karnataka Medical Council has been awarded for this. We will have the inaugural function of the CME at 10 o'clock on Sunday. I request members to please come for that. 2 major events that would occur other than our good academic feast that's going to be happening. One is the release of Medilore e-newsletter. We have formulated a 3-monthly e-newsletter which will be released, and the launch of our website, which will be happening on the inaugural function. That's again at 10 a.m. to maybe 10:45. That's the inaugural schedule. And then we have the day long of wonderful speakers with wonderful sessions that are going to be there. We are going to have 2 orations that are going to happen on that day. Dr. K.R. Kinney oration by Dr. Devi Prasad, and Dr. Sudhakar Shetty oration by Dr. Ashish Dikshit will be giving it. On World Health Day, that's 7th of April, that's the first Friday, we, as per the instructions from the Central IMA, we have got instructions that it has to be celebrated as the World Health Day. So we will be having a general body meeting on that day. We will be announcing the schedule and what will be going to happen on that day. So they have given instructions that we are supposed to do a general body meeting. We have to honor the medical social workers and the nurses, and then we have to involve other branches of medicine, the integrative medicine supposedly. So we'll be discussing and we'll be sharing you the program schedule shortly. The annual sports event, which I think has been finally scheduled for April 23rd, that's the Sunday, the last Sunday of April. We have the cricket match for the men, the throw ball, shot put and telecot tournaments for the women. I think all the teams are gearing up well, and I think this will be the event that will be awaited for. So these were the activities that we had for the February and the upcoming activities that we have. Any other comments and any suggestions from the members? Anything to be announced? Thank you, Raghavendra. I think I told him somewhere in January that I would want you to speak and organize the company for that. So he has done that. And I thank him for selecting such a relevant topic and such an appropriate topic and speaking so well. Thank you, Raghavendra, for agreeing to that. I thank MCure Pharma, the Tenecliptase team, for having sponsored this meet, and they have been with us. I thank them again. I thank Abbakka TV, who is covering our meeting and has been always covering the meetings for us. I thank Dr. Kavya Samhita for doing the MC today. And I thank all the team of IMA, our secretariat, Sushant and others, as well as Kamath Caterers for today's function.